recuperate. Because you don't want to be sick. All right, you can hear me? Yes, thumbs up. And you can see the PowerPoint presentation? Thumbs up. Okay, let's begin then. All right, welcome back. So we're going to talk about gastroenterology, endocrine, and reproductive. So first of all, let's talk about esophageal motility disorders. How are we going to distinguish these three disorders? Via what? Esophageal manometry. So on the exam, they're going to show you on the right side of the slide an example of esophageal manometry. How are we going to do this? So the patient swallows, right? And then the pressure changes in esophagus is measured. Let's talk about achalasia. So what is this? Inability to relax the lower esophageal sphincter, LES. Where can we find the LES? At what junction?
Gastroesophageal junction.
Esophageal junction. So this is a loss of lower esophageal peristalsis. Why? The ganglion cells in the myenteric plexus are gone. They're not there. Embryologically, they're not present. So what are the causes? Idiopathic, or there's another one, Chagas disease, trypanosoma cruzi. Treatment for trypanosoma cruzi, for Chagas. Starts with letter N. What is it? Nifortimox, right? Don't forget. Aside from achalasia, what else can we have in Chagas? Dilated cardiomyopathy. So when you think about Chagas, think about dilation. Everything is dilated, right? So esophagus is dilated, the heart is also going to be dilated. Achalasia, inability to relax what? LES, due to what? Missing ganglion cells in the myenteric plexus, causes idiopathic and often chronic Chagas disease. What are the symptoms? Dysphagia to both solids and liquids. You can have regurgitation of food. You can have retrosternal burning, similar to GERD, right? And sometimes, because the food accumulates in the esophagus, you can have bad breath. Look at the esophageal manometry tracing, right? So how are we going to test achalasia? Via endoscopy. But what's wrong? You cannot pass the scope beyond the LES, the lower esophageal sphincter. And when we look at esophageal manometry, what happens? You can see no peristalsis in the distal esophagus. Due to what? Incomplete lower esophageal sphincter relaxation. So what happens to the pressure? If there's no peristalsis, there's an incomplete relaxation. Your LES is always clamped. What happens to the pressure? What do you think happens to the pressure? It increases. Right? So let's look at the manometry here. So you have a normal and achalasia. Pharynx, there's nothing wrong. Upper esophageal sphincter, there's nothing wrong. Let's look at the esophagus. They divide it into three: upper, middle, lower. Look at the lower one. In the normal patient, the lower esophageal sphincter pressure is increased, right? What happens now to achalasia? Achalasia is decrease, correct? And then look at the lower esophageal sphincter. You have much lower pressure in a normal patient than achalasia, so it's less than, okay? Do I need to memorize the tracing of esophageal manometry? I think it's good to know what happens to the pressure. Why? Because on the exam, they're going to give you this one, but this one, it only helps you with the diagnosis. In the vignette, they're going to give you the symptoms, the signs and symptoms, and they're going to give you esophageal manometry just to confirm. Okay, so what happens? Look at the lower esophageal sphincter pressure. Look at that. In a normal patient, it's much lower, right? In achalasia, it's not. Why? Because LES is not relaxed. Therefore, the elevating, resting LES pressure is increased. Okay, you can also do barium swallow. So barium swallow, on the right side here, you can see the bird's beak appearance, a dilatation of the esophagus proximal to the constriction. What's the treatment then? We could do pneumatic dilation. We're going to insert a balloon and poop, Open it up. Or you can do endoscopic myotomy. Not everyone can have endoscopic myotomy. For example, poor surgical candidates, if they are poor surgical candidates, you can give them sublingual nitrates before meals. But some patients forget that, or they don't want to be heavily medicated. Or you could do a botulinum toxin injection of the LES. You could also do that one. But the most definitive treatment for achalasia is surgical or endoscopic myotomy. Next, diffuse esophageal spasm. What can we see here? Corkscrew appearance of esophagus. How does the pain of this diffuse esophageal spasm, how do you describe it? Your DES. It is comparable to what? That's my question.
Would it be like hiccups?
Careful. It's comparable to MI. It's comparable to MI. You think that the patient is having an MI, but it's not an MI. It is a diffuse esophageal spasm. How do we know? Let's look at the Boreham esophagram. They're going to show you this. Corkscrew. Look at the esophagus. It's corkscrew, right? You have a corkscrew appearance of the esophagus. So, what causes this one? You have excessive simultaneous contractions. So the inhibitory innervation of the esophagus is gone. That's why you have simultaneous contractions. So you have dysphagia for both solids and liquids. You can also retrosternal burning, similar to GERD, or the patient is having angina, anginal pain, chest pain that mimics angina, MI. Endoscopy is normal. Let's look at the esophageal manometry, guys. So diffuse high pressure contractions where? In the middle and lower part of the esophagus, right? Look at the normal and the DES, esophagogram. The upper esophagus is the same. Where are the contractions? Mainly the middle and the lower part. You can see this zigzag pattern, like it goes down, goes up, down, up, down, up, down, up, right? So that's where you know it's diffuse esophageal spasm. Everything else is normal, okay? So what can we give? We can treat them with what? Smooth muscle relaxants. You can give them PPI for GERD. Example of PPI? Example of PPI.
Omeprazole?
Be careful. Why? What's the side effect of omeprazole? What happens to the QT?
Prolonged?
It can prolong QT. You can also, but the first line of drug treatment is what? Diltiazem. What is diltiazem? What class of drug is diltiazem? Beta blocker? Calcium channel blocker? What are we thinking? These are your non-dihydropyridine, CCBs, right? Calcium channel blockers. You have your diltiazem, you have your verapamil, right? Okay. So other alternatives for this, of course, isosorbate dinitrate, right? Smooth muscle relaxants, of course. Sildenafil, right? What's the mechanism of action of sildenafil? Mechanism of action of sildenafil?
It's a phosphodiesterase
Phosphodiesterase inhibitor, exactly. So you inhibit phosphodiesterase, right? So you have, what happens to the blood vessels of the penis? They expand, basically. So reduce blood flow back to the heart, right? How about botulinum toxin injection? Botulinum. What's the mechanism of action of botulinum? Go ahead. Botulinum, what does it do? What happens to acetylcholine, guys?
It prevents the
uptake of your acetylcholine.
Choline, by binding to the presynaptic.
Exactly. Good job. But for this one, for DES, high yield first line drug treatment is diltiazem. Okay, don't forget that. Next, Zenkers diverticulum. So this is a herniation at what? Killian's triangle. Of course, they'll in the vignette, they're not going to say Killian's triangle. They're going to say junction of esophagus and the pharynx, or part of the hypopharynx, or proximal to upper esophageal sphincter. You know they're going to be tricky. They're not going to say Killian's triangle. So what is this? Is this a true diverticulum? Yes or no? And how can we know if it's a true diverticulum? What's the difference between a true diverticulum and a false diverticulum? Guys, what happens to the mucosa? If it's a true diverticulum, right? All of the layers, right? Your mucosa, submucosa, right? All the muscularis, all of the serosa, they herniate, right? However, false diverticulum, does it involve all the layers or only a couple of layers?
Only a couple.
Only a couple of layers. So this one, Zenkers diverticulum, is what? True or false then?
False.
False
Is
diverticulum.
Meckel's diverticulum the only true diverticulum?
I think no. That statement we can modify it. It's not the only diverticulum, but it's right. It is a true diverticulum for Meckel's. What are the rules for Meckel's? Rule of twos. Tell me the rule of twos.
2% of the population, 2% are symptomatic. It's 2 times more in males than females. It's 2 feet proximal to the ileocecal valve, and it's less than 2 inches long.
Exactly. Excellent.
And you can have 2 types of mucosal lining.
Yes.
Gastric
You can
and
do
hepatic.
hepatic and gastric tissue. How do we diagnose Meckel's? What's the diagnostic test?
Per Technitate T99.
Technetium scan, of course, the Meckel scan. Excellent. So this one, in Zenkers, it usually results in what? Chronic swallowing problems. So your cricopharyngeal muscles, they must relax, right? To allow the food to pass. However, for this one, they don't relax. So you have difficulty in swallowing. So this leads to the chronic high pressure in the pharynx to force your food down. This leads to diverticulum, a herniation through the muscular wall. All right. So how do we see this in the vignette? So usually oropharyngeal dysphagia to solids only. And then what else? Regurgitation of undigested food. Sometimes they're going to say bad breath there. So halitosis. Why? You have a food trapped in the diverticulum. What's the diagnosis? Barium swallow. What's the treatment? Surgical or endoscopy resection. So we also have some esophageal webs and rings. What are these? These are extensions of or protrusions of mucosa into the lumen. Webs meaning eccentric membrane, often proximal, that protrudes into the lumen, while rings are concentric membrane that is often distal, right? That protrudes into the lumen. So it's often asymptomatic. It can obstruct movement of food. What's the diagnosis? Endoscopy. What's the treatment? We can do endoscopic dilation. Pay special attention to Schatzkis ring. This is the most common type of esophageal ring. What is this? Where is the ring? Ring is at the squamo-columnar junction. So proximally, you have a squamous mucosa. Distally, you have the columnar, right? This is the most common cause of dysphagia to solids. Look at the barium esophagogram here. You can see the squamo-columnar junction. Here, this is where your Schatzkis ring is. Okay, this is the histological portion of that squamo-columnar junction. Another high yield is PVS, Palmerinson syndrome. Don't forget the triad: iron deficiency anemia, dysphagia, esophageal web. Iron deficiency anemia. What kind of anemia is it? Macrocytic, or normocytic? What kind of anemia is iron deficiency?
Is it
Is
microcytic?
it big, macrocytic, or microcytic? Microcytic. Is it normochromic, hypochromic, hyperchromic?
Hypochromic pencil cells.
Exactly. So you have IDA, iron deficiency anemia, dysphagia, and esophageal web. In the vignette, they're going to say the tongue is red, right? Beefy red tongue. When you see that, think Palmerinson syndrome. Why is it red? Because you damage the mucosal layer of the tongue due to low iron, right? And this exposes the blood vessels. Most common in what? Middle-aged white woman. Why do we care about Palmerinson syndrome? Increased risk of squamous cell carcinoma of the esophagus. Infectious esophagitis, of course. Candida, what can we see in the vignette? White membranes. You can see pseudohyphae on biopsy. If it's HSV1, it involves the esophagus, and you can see punch out ulcers. Look here, the pathological slide of HSV esophagitis. You can see like it's hollowed out, right? It's a punch out ulcer. Now, compare that one with the CMV. CMV, normally due to AIDS, right? You can have CMV esophagitis. And what kind of ulcers? Linear. So you have linear ulcers. For esophageal candidiasis, they look like white membranes on the esophagus. Okay? Okay, for HIV patient, mild symptoms and thrush, what can we give them? Fluconazole, right? And if they have severe symptoms with no thrush, endoscopy. High yield, know this one. Know the findings, diagnosis, and treatment. So white plaques, what are we thinking? Candida. What's the treatment? Fluconazole. Linear ulcers, CMV. What's the treatment? Ganciclovir. What if they are sensitive to, they are resistant to ganciclovir? What can we give? Starts with F.
Yeah, Nick, I think you're doing like more T5 stuff.
Oh, is this T5 stuff? Sorry.
Yeah, we didn't do treatments for.
Okay.
We
Right.
did
So just make sure the diagnosis, all right? So linear ulcers, CMV, and then punch out ulcers or vesicles, HSV. What's the difference between HSV1 and HSV2? Where can we see HSV1?
HSV1 is mainly oral and HSV2 is mainly genital.
Exactly. Can they mix?
Yes.
Yes, of course, because humans are very creative. Eosinophilic esophagitis. One word, allergic reaction, right? So what is this? When you look at the biopsy, what can we see? Eosinophil predominant inflammation. Look here. So this is the gross image, right? We zoomed in, and what can we see? We can see eosinophils. How do we know they're eosinophils? They're bilobed, right? And they're colored red. They're stained red. So those are your eosinophils. So the patient has allergic reaction, and then suddenly the patient has dysphagia, right? And they show you this slides, then think, okay, eosinophilic esophagitis. However, make sure you rule out other causes of esophagitis. For example, GERD. It's a classic scenario. Dysphagia, poor response to GERD treatment. Even you give them PPIs, it still doesn't work. And you look at the biopsy, eosinophils on biopsy. Those are the classic scenarios. First line treatment, dietary modification. So you do food allergy testing, you do elimination diet. Other treatments, you can give them fluticasone inhaler. Why? Because normally if you have asthma, you can have eosinophilic esophagitis. Okay? Another high yield is Mallory-Weiss tear. So you have a damage to what? Esophageal mucosa at your GE junction. Causes what? Painful, high yield, painful hematemesis. So you have epigastric pain or pain in the back. Caused by what? Severe chronic vomiting. Due to what? Alcohol use or bulimia. What's the iatrogenic cause of Mallory-Weiss tear? NG tube. Actually, inserting an NG tube can precipitate a Mallory-Weiss tear. Diagnosis, endoscopy. What's the treatment? PPI or plus and minus endoscopic therapy. The worst complication of Mallory-Weiss tear is Boreham Syndrome. What is this? A rupture of the esophagus, not caused by trauma. It is caused by what? Severe vomiting or retching. So the air exits the esophagus. So what happens? Look at the X-ray here. You can see air in the mediastinum. Look here. That's an air. next to the left internal carotid artery. And then here also, you can see an air. So my pointer is pointing at the air. Here at the what? At the aortic arch. Okay, so you have air in the mediastinum, or chest X-ray, we call this one pneumomediastinum, or air under skin in the neck. So this is an AP view. So we can't really see the, I'm sorry. This is a PA view, posterior anterior view. So we can't really see below the neck. But when you look at an AP view, you can see subcutaneous emphysema. So gastric contents may enter the mediastinum. You can also have chest pain and dysphagia. What's the moral lesson of the, what's the moral lesson here? Do not drink, okay? So how do we diagnose Boreham Syndrome? Contrast esophagram. It establishes exact location of the perforation. So you give gastrographin, right? You give gastrographin. We don't want to use barium here, right? For esophagram. Why? Because it avoids inflammatory response in media. So if we give them barium and it leaks, right? It induces an inflammatory response, and we don't want it in a patient. So we use less, what do you call this one? An agent that is less, that is much more better than barium, which is gastrographin. Alternative, you can do CT of the chest, which can show edema and air, but not precise location. What's the treatment? NPO, antibiotics and PPI, and surgical repair in some cases. So you can see here the esophageal perforation. What site of the esophagus can we see Boreham Syndrome? Is it the upper, middle, or lower esophagus?
Distal esophagus.
Distal esophagus. Why do you think it's in the distal esophagus? What's missing in the distal esophagus in terms of anatomy? Let's go back to anatomy. What's missing in the distal esophagus? There is no
squamous cells. I mean,
there is no adventitial layer in your distal esophagus. That's why it is prone to rupture. All from the upper to the middle, you have adventitia, a serosal layer, except for the distal esophagus. That's why it's much more prone to rupture. Okay. Next, GERD, reflux of gastric contents from stomach to esophagus due to what? Failure of your LES. You have a decrease in LES tone. It causes then irritation of your esophageal mucosa. Classic symptoms: chest pain, retrosternal burning, occurs after meals, often when lying flat. You can also have regurgitation and dyspepsia. Other symptoms like asthma, adult onset asthma. Don't forget that one. Okay, wheezing, cough, dyspnea. You can have damage to the enamel of your teeth, so you're prone to dental caries and dysphagia. Risk factors. So this is me during the pandemic. What are the risk factors? Alcohol, smoking, obesity, fatty foods, caffeine, chocolate, peppermint, and hiatal hernia. Two types of hiatal hernia. What are those? Two types of hiatal hernia. Sliding.
I don't know.
And paraesophageal. How do we know the difference? The JE junction. If the JE junction is displaced, it's not below the diaphragm, it's above, then it's a sliding hernia. If it stays on its original location, it's a paraesophageal hernia. That's the difference. How do we diagnose GERD? Clinical, of course. And then you can have endoscopy in alarming symptoms. Why? Because it may indicate esophageal cancer. What are the alarm symptoms? Onset at age more than 60. Bleeding, IDA, weight loss, dysphagia, persistent vomiting, and then GI cancer in a first-degree relative. So you do an endoscopy for these alarm symptoms. What can we say to the patient? Lifestyle modification is always the first thing that you need to prescribe. Weight loss. Tell them not to smoke. Tell them to avoid triggers like fatty foods, caffeine, chocolate, spicy foods, carbonated beverage, bye-bye Coke, peppermint. What's the management? Histamine blockers, famotidine, ranitidine. It blocks histamine receptors in parietal cells. So what if I block histamine receptors in parietal cells? What will happen? What is the function of the parietal cells?
To make hydrochloric acid.
Make hydrochloric acid, of course. If you block the histamine receptors in your parietal cells, then no more production of HCl. If it does, however, histamine blockers is not always the preferred treatment for GERD. The answer is PPIs, proton pump inhibitors. You have omeprazole, pantoprazole, lansoprazole. So it inhibits H+ pump in parietal cells. What's the exact mechanism of your PPIs? It inhibits the... How does it inhibit the H+ pump in your parietal cells? The sodium potassium ATPase in your parietal cells, it inhibits that one. Okay? So for GERD, you can give a trial of histamine blockers, but the definitive treatment is proton pump inhibitors. They end in azole, omeprazole, pantoprazole, lansoprazole. HO blockers, think about idine, famotidine, ranitidine, cimetidine. They all end in idine. Management, mild GERD, lifestyle changes plus low dose H2 blockers. If it's very severe, you can give daily PPI therapy. What's additional testing for GERD? Esophageal pH and impedance testing, rarely done. A catheter is inserted through the nose into the esophagus, left in place for 24 hours, right? If I'm the patient and you're gonna tell me you're gonna insert an NG tube and left within 24 hours, I'm gonna be mad because it's very, very, how do I say this? It's very uncomfortable, right? So what you monitor the pH and impedance. What do I mean by impedance? It means a change in electrical flow. This is rarely done, so I think low yield. Common indications for this testing is if you have refractory disease. If you're given daily PPI, right, still doesn't work. Okay, let's titrate up the PPI to what? BID, twice a day. Still, it doesn't work. There might be something, right, behind why is it not working. So you do esophageal pH and impedance testing. Or the patient has atypical symptoms, possibly due to GERD. Okay, so it just determines the height of regurgitation into the esophagus. If you're given PPI, BID, like twice a day, doesn't work. What are the causes of refractory disease? Medication doesn't work. So it might be poor compliance with medical therapy. Maybe they're not taking it like BID. Or we have functional heartburn associated with what? Anxiety and depression. So for this one, you need to call the psychiatrist because they need psychiatric medications. Another cause is non-acid reflux, which is reflux after meals. So this is reflux without acidic pH on testing. It indicates acid suppression has been achieved. You treat non-acid reflux with baclofen, which is a muscle relaxant. So it just reduces the transient LES relaxations. That's why it works. Baclofen, muscle relaxant, non-acid reflux. Why does it work? It reduces the transient LES relaxations. Delayed gastric emptying is a refractory disease that can cause GERD. So what is this? It is diagnosed by gastric emptying studies. So the patient consumes technetium or an egg substitute. For this one, we treat them with metoclopramide. Residual acid reflux, it is rare in patients on twice daily PPI. However, it happens. So you can add a nighttime H2 blocker, definitive treatment, surgery, or endoscopic treatment. Or you can do Nissen funduplication for GERD. These are advanced management options for GERD. Nissen funduplication, what is this? High yield. The stomach is wrapped around the lower esophageal sphincter. It can be done via surgery or endoscopically. Hiatal hernias. Hernia, What do we mean by hernia? Something is protruding, right? Either mucosa, submucosa, it's herniating to something. Here, the stomach is herniating into the thorax, which can lead to GERD. What's the major risk factor? Obesity, right? How do we diagnose? Endoscopy, X-ray, CT scan, MRI. I yield most sensitive test, okay? Always look at that, the wording. Most sensitive test. Barium swallow. Don't forget that. So there are two types. Sliding, which is the displacement of GE junction, the gastroesophageal junction above the diaphragm. We call that sliding. You can see an hourglass appearance here. So it is often symptomatic, can lead to GERD, right? What's the treatment? Same as GERD. Surgical treatment only in refractory GERD. Type 2, esophageal. Why is it paraesophageal? The JE junction stays in place. Only a part of the stomach is protruding, right? The fundus part of the stomach is protruding. There's a defect in your phrenoesophageal membrane. Classic finding, bowel sounds in lung fields, high yield. Paraesophageal hernia, classic finding, bowel sounds in lung fields, often occur after surgery. For example, GERD surgery, or they do a myotomy, right? Achalasia treatment, or a partial gastrectomy. It can cause epigastric pain, nausea, retching, and GERD symptoms less common. What are the complications of GERD? First, erosive esophagitis. You have worsening of GERD symptoms. You have erosions in your esophageal mucosa. Treatment, same as GERD. It can progress to strictures, which is fibrous narrowing of the esophageal lumen. This is due to healing of the esophagitis. Treatment, endoscopic dilation. Then, it can develop to Barrett's esophagus and adenocarcinoma. So there is a progression, right? You have GERD, then erosive esophagitis, which can lead to strictures. Then it leads to Barrett's esophagus. Then it leads to adenocarcinoma. What is Barrett's esophagus? This is metaplasia of the esophagus, meaning a transformation, right? Metaplasia, from squamous epithelium to intestinal epithelium. So what if I have Barrett's esophagus? Increased risk for esophageal adenocarcinoma. Look at the pathology slides. Normal esophagus is squamous epithelium. Barrett's, you can now see columnar epithelium, and you can see intestinal mucosa here. See that? You can see intestinal mucosa. Look at that with your goblet cells. Metaplasia of esophagus. Transformation from one cell to another kind of cell. Metaplasia of the esophagus. So how do we identify this one? Endoscopy, of course. GERD. So you need to take a biopsy to look for adenocarcinoma. You need to still to continue treatment for GERD. And then you can have surveillance endoscopy. Look at the slide here. This is a good image of a Barrett's esophagus. You can see the normal esophagus. I'm pointing at that, right? So that's normal. It's squamous, it's white. And then you can see the intestinal portion, the pink and the reddish part. Worst comes to worst, Barrett's esophagus develops into esophageal cancer, adenocarcinoma, or squamous cell carcinoma. Adenocarcinoma occurs in where? Lower esophagus near the stomach. Risk factors similar to GERD and Barrett's. obesity, smoking, right? Squamous cell carcinoma, it occurs in mid-esophagus, associated with dietary factors. So, two types, adenocarcinoma, squamous cell carcinoma. Adenocarcinoma, think about GERD, right? Risk factors similar to GERD. Squamous cell carcinoma, associated with dietary factors. Adenocarcinoma is lower third, squamous is mid-esophagus to upper esophagus. Risk factors for esophageal squamous cell carcinoma from mid to upper esophagus. Smoking, alcohol, dietary factors, right? If you love cured meats or cheese or hot beverage, hot tea, commonly in Asia, right? Esophageal disease, of course, achalasia and strictures. In the vignette, they're gonna say an East Asian person who is having like signs and symptoms of esophageal Squamous cell carcinoma, then think, okay, major risk factor, dietary factors for this person. Why? Because in Asia, we love cured meats, right? But remember the nitrogen compounds. And we love to drink tea, so hot tea, hot beverages. Of course, lymph nodes, do I need to know that? No, but just remember, esophageal cancer, it can metastasize to your lymph nodes. What are the clinical features? Progressive dysphagia, meaning you have dysphagia to solids first, and then it progresses to liquids. Why? Because the tumor is growing. Okay, first you can still drink, but then since the tumor, look at the size of this tumor here on the pathological slide, it grows, then you can no longer tolerate drinking liquids. Weight loss, hematemesis, and upper esophageal tumors. You can have hoarse voice. Don't forget your recurrent laryngeal nerve can be impinged, or a cough if the trachea is involved. How do we diagnose? Endoscopy with biopsy. We need to take a biopsy to look at the cells. What's the treatment? Resection, chemotherapy, radiation. Let's talk about H. pylori. So H. pylori, gram-negative bacteria, urease positive, meaning it hydrolyzes urea, it produces ammonia, right? So it forms ammonium chloride, which is damaging to the stomach. So what if I have H. pylori in my stomach? That hydrolyzing urea, that converts, that produces like ammonium, which is very, very alkaline, right? So what? You're losing your protection from stomach acid, thereby increasing the pH of the stomach. You have gastroenteritis and increase in acid production. 50% of the world population is infected. It's asymptomatic. Most of us are carriers. It can cause chronic inflammation of the antrum of the stomach. Where is the antrum? Here is the antrum. Associated disease with H. pylori, think PUD, peptic ulcer disease, gastric adenocarcinoma, or a gastric maltoma. Gastric maltoma, usually highly associated with H. pylori and B-cell cancer in the stomach. This is how they look like in immunohistochemical staining. Don't forget that image. They look brown in immunohistochemistry. Diagnosis, GI symptoms. Biopsy, what can we do? We can also do urease testing, right? Stool antigen, or the famous high-yield urea breath test. So what is this? Patient swallows urea with isotopes, then you detect carbon dioxide in exhaled breath. So they swallow, gulp, 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 the urea with isotopes, then you wait, there's a machine, they exhale, then you detect carbon dioxide in exhaled breath, and then you can see if urease is present, right? Is urea split, yes or no? How do we detect that? Is urease present? If urease is present, then there's no H. pylori. If it's absent, then there is H. pylori. Or you can do serology. It detects IgG. However, for serology, it does not indicate active or current infection. What's the treatment? High yield. They love this. Triple therapy, right? PPI, your ozoles, omeprazole, pantoprazole, clarithromycin. What is clarithromycin again?
Antibiotic.
It's an antibiotic. What's amoxicillin? It's still an antibiotic, right? Metronidazole. So all of them are your antibiotics, right? Don't forget clarithromycin, macrolides, right? Resistance is common. Give an example of a macrolide. Aside from clarithromycin, you can have erythromycins, right? Don't forget. Macrolide is also what? What happens to QT? It can also prolong the QT for your macrolides. If H. pylori is present, then you need to have a quadruple therapy. So PPI, metronidazole, tetracycline, and bismuth. Okay, so 4. So triple therapy for 7 to 10 days, right? If you have resistance to clarithromycin, then you can't use triple therapy. So what are we going to use? Quadruple therapy. Read the vignette carefully. If it says macrolide resistance, you can't use triple therapy. You need to use quadruple therapy, which is PPI, metronidazole, tetracycline, bismuth. Side effect of tetracycline? What happens to your teeth?
I don't know.
Orange discoloration of the
Discoloration.
Yeah, don't forget that. Orange discoloration of the teeth. That's your. I remember it. Teeth recycling because of the teeth. Okay.
Thanks for the mnemonic.
Yeah, that's a good mnemonic. So testing, you need to repeat again to confirm eradication. How do we do that? Simple steps, right? Breath test, the urea breath test. It's very simple. Stool antigen or a biopsy. If treatment fails, alternate regimens can be tried. Now, another tie-in with your H. pylori, peptic ulcer disease. So either H. pylori or what? Chronic NSAID use. Now, NSAID, mechanism of action. What's the mechanism of action of your NSAID?
Flux COX.
COX-2 inhibitors, exactly, right? So what if I inhibit COX-2? What happens to the pathway, right? So you have phospholipase A2, right? This is term 1 stuff, correct? You have lipoxygenase and you have COX, right? Lipoxygenase, HP, your LTAs. And then you have COX-1 and COX-2. Then what? You have inflammatory markers, basically, right? So if you inhibit COX-2, what happens to your inflammatory cascade? Gone, basically, right? Your thromboxane A2, your prostaglandin synthesis is gone, okay? Aspirin is an irreversible inhibitor of COX-1 and COX-2. So if I'm too tired and every day I take NSAIDs, right, I can develop PUD. Or also, if I smoke and I drink alcohol, so triple whammy. I have H. pylori, I take NSAIDs every day, I smoke, and I drink alcohol. Wow. Then you can have PUD. Most common location is where? The lesser curvature. This is your, where's the lesser curvature? Here is your lesser curvature, and this is your greater curvature. What artery can we see in the greater curvature? What supplies the greater curvature of the stomach? What artery? Your gastroepiploic artery, right? Or gastroomental arteries. Most common cancers of like adenocarcinoma of the stomach usually can be found here in the lesser curvature. Okay, so gastric ulcer, pain is worse with meals. Why do you think pain is worse with meals in gastric ulcers? Think about it. Why do you think it is worse with meals?
Because of the acid release.
Of course, when you're eating, right, your stomach is adjusting. So the food stimulates acid release. That's why you have worse with meals. And you can see they are cachectic, right? It can lead to weight loss. People who have gastric ulcers are skinny. 70% associated with H. pylori. It can cause adenocarcinoma. So they need to be biopsied. What are the malignant features of adenocarcinoma? Look at this wonderful image here. You have an ulcerated mass protruding into the lumen. You have folds surrounding the ulcer and irregular or thickened margins, right? Gastric ulcers, H. pylori, it can cause adenocarcinoma. And look at the malignant features. You have ulcerated mass that has folds surrounding the ulcer crater, irregular or thickened margins, that is protruding into the lumen. So what if I have gastric ulcers? What are the complications? Perforation, upper GI bleeding. Don't forget, anatomy is very important, right? The classic vessel is your left gastric artery. See this in your upper lesser curvature of the stomach. You have the left gastric, right? So you have left gastric here, and then you have SMA. A branch of the SMA is what? Your splenic artery, which devolves into your short gastric, right? And this is your epiploic. This is what I'm talking about. The gastroepiploic. Your left and right gastroepiploic, which feeds the greater curvature of the stomach. Don't forget anatomy, guys. Okay? SMA, another branch, you have your proper hepatic and gastroduodenal. So for gastric ulcer complications of upper GI bleeding, think about left gastric artery. How do we delineate anatomically upper GI bleeding from lower GI bleeding? In terms of anatomy, how are we going to delineate upper GI bleeding from lower GI bleeding? What's that ligament? What's that ligament that delineates upper GI bleeding from lower GI bleeding? Basically divides your GI into upper and lower. What do we call that ligament?
Can you tell?
Ligament of Treitz. Treitz. Your ligament of Treitz.
Doesn't sound familiar at all.
This is your duodenal ligament. Remember.
Oh, I never heard Treitz before.
Remember the duodenum, right? So you have the ligament of Treitz. It's like the duodenum, it goes up, and this ligament, it holds it. It attaches to the abdominal wall. It holds it up. Okay, this is very, very important. Why? When you're doing gastrectomy, when you're cutting the stomach, right? When you're doing surgical gastrectomy, you need to know where's the ligament of Treitz. Should I cut how many centimeters from the gastric incisura, or from the pyloric sphincter? How many centimeters and how many centimeters? If you're doing Roux-en-Y gastric bypass, you need to know the ligament of Treitz. Okay. So upper GI bleeding, think what artery is the most common? Left gastric artery, right? Also, gastric ulcers can have gastric outlet obstruction. Due to what? We have scar formation there. So you can have nausea, vomiting, and distension. This is term 2 stuff. Go back to term 2 and check the anatomy. So the duodenal ulcers, most commonly they are anterior, right? They are benign, right? So upper GI bleeding due to duodenal ulcer, what is the common source? High-yield gastroduodenal artery. So this one, a branch of your superior mesenteric artery. So it's here, the gastroduodenal. So for gastric ulcers, most common source of bleeding is the left gastric artery. For duodenal ulcers, most common cause of bleeding is the gastroduodenal artery, right? So you can also have pancreatitis and perforation. Zollinger-Ellison syndrome, high yield. This is a gastrinoma. Gastrinoma, oma, it's a tumor of what? Gastrin. Gastrin secreting tumor. You have increase in acid production, and you have multiple duodenal ulcers. Most commonly arise duodenal wall. Diagnosis: serum fasting gastrin level, or a secretin stimulation test. So first you can do serum fasting gastrin level. If it's more than 1,000, then it is gastrinoma. However, the most common used test is secretin stimulation test. I think that's a high yield one. Secretin stimulation test. So it increases gastrin production only in gastrinoma cells. So it's much more specific, right? So the normal cells, they are inhibited by secretin. So if you have a positive test, you have an increase in gastrin greater than 120, okay? So Zollinger-Ellison syndrome, gastrin secreting tumor. secretin stimulation test. If it's positive, gastrin is more than 120. However, caution, you cannot perform this one in patients who's taking PPIs, okay? Who's taking omeprazole, pantoprazole, all those ozoles. Why? You have a false negative secretin stimulation test, okay? What's the treatment for ZES? Surgery. If you have an ulcer, what can we do? Avoid NSAIDs. H. pylori treatment, if you do the urea breath test, stool antigen test, or biopsy, or PPI, therapy of choice, and you can do endoscopy, endoscopic surveillance of your gastric ulcers. Now, let's talk about adenocarcinoma. These are asymptomatic. Some symptoms are non-specific, right? I want you to know the two types, intestinal and diffuse. Those are high yield. So look at this one. This is intestinal type. So what can we see? It appears large ulcer. You can see like irregular margins, right? It is protruding. It is big. It results from what? Intestinal metaplasia due to chronic inflammation. For gastric adenocarcinoma, think H. pylori. H. pylori, okay? Most common in lesser curvature. Here, lesser curvature. You can see this is the incisura. The incisura is a part of your pyloric antrum. Very important in doing gastrectomies, right? So gastric adenocarcinoma, intestinal metaplasia. Why am I having metaplasia? Chronic inflammation. Why am I having chronic inflammation? Due to what? Either autoimmune gastritis, less common. What's the most common cause? H. pylori. Where anatomically can I see gastric adenocarcinoma? Lesser curvature. Other risk factors, chronic gastritis, obesity, smoking, but I want you to think H. pylori infection. First, less common autoimmune gastritis. Blood type A. Well, this is like for trivia questions. 20% increased risk of gastric cancer. I don't know why. You could tell me after. Dietary nitrogen compounds, of course, are nitrates, nitrites, nitrosamines. Careful with bacon, smoked meats, guys, okay? Bacon, sausage, and ham. And sometimes linked by some case control studies for the smoked meats, okay? So all the good things in life, guys, be careful. But, you know, only in moderation, right? Only in moderation. So for the diffuse type, so that's intestinal type. Intestinal type, H. pylori, chronic inflammation. You have this large ulcer with irregular margins, right? Now for diffuse type, most common. However, this is very aggressive. Poor prognosis. Why? Because of loss of E-cadherin. Question, what's the function of your E-cadherin? Let's go back to term 1. What is the function of E-cadherin?
It helps cells adhere to each other.
Exactly. Now, you lose the expression of your surface adhesion molecules, right? Therefore, the tumor will gonna grow diffusely. High yield. You can see Linitis plastica. Please make sure you know this image. Linitis plastica. So you can see the stomach is thickened like leather, right? Or here on the lower left, signet ring cells. Why does it look like this? Because the mucin is formed and it pushes the nucleus. Look at the nucleus here. Push to the periphery. You have a lot of mucin that is forming, and the nucleus is pushed to the periphery. It looks like a signet ring. This is an example of a signet ring. So gastric adenocarcinoma, poor prognosis. Why? Loss of E-cadherins. What can we see histologically? Linitis plastica. Stomach looks thickened, looks like leather, and signet ring cells. Why signet ring? The mucin that is formed is pushing the nucleus to the periphery. What's the diagnosis? Endoscopy, and then we do a biopsy. Then we stage it, of course. CT or PET. What is PET scan? In layman terms, what are we measuring in a PET scan?
It's positron emission tomography, and I think you're measuring the use of glucose.
Exactly. So we call it effect. What do we call that effect? Cancer cells increases the uptake of glucose. We call that one Warburg effect. I think it's in one of your notes. I'm not sure. So that's a Warburg effect. So tumor cells increase metabolism, right? They need sugar. They need glucose to grow. So you have increased uptake of glucose. We can see that in a PET scan beautifully. We call that effect the Warburg effect. What's the treatment then if you have adenocarcinoma? So gastrectomy, you cut the portion of the stomach, which I witnessed, I assisted yesterday, gastrectomy. Or we could do chemotherapy, neoadjuvant chemotherapy. Remember, neoadjuvant is always before surgery. Okay, don't confuse that with adjuvant therapy. Big difference. Big difference. Neoadjuvant chemotherapy before surgery. Why? You need to decrease the size of the tumor. If it's too big, you give neoadjuvant before surgery. After surgery, you need some treatment, some chemoadjuvant chemotherapy. Be careful with the wordings, okay? They might trip you up with that. If it's metastatic, unfortunately, palliative care. What are the other special findings for gastric adenocarcinoma? Acanthosis nigricans, hyperpigmented plaques of skin. What layer of the skin do you think is thickened in acanthosis nigricans?
The epidermis?
Okay.
Or is it the dermis and it just appears?
What are the layers? I'm talking about the layers. You can search online. I mean, this is not like memory, right? What part do you think? What are we thinking, guys? What part is acanthosis nigricans? What skin layer? You have hyperkeratosis of your...
Are you talking about the stratum corneum?
The basal
Is it
layer?
the stratum corneum or not?
Well, you said search it, and it said the basal layer in my research.
It is. Yeah, okay. So melanocytes of the basal layer of the epidermis, right? Okay, I'm just making sure. So you have hyperpigmentation, right? Classically on the neck and axilla. Also associated with obesity and diabetes, okay? Acanthosis nigricans. This is a picture of the axilla. Rarely associated with malignancy. However, in gastric adenocarcinoma, it is most common. Okay? Don't forget that. Okay, let's do some work. See those question marks? Let's answer those, okay? Now you need to do some work. Let's do this. Okay, defect lateral of the midline and nose sac. Let's look at the image here. What do you think is that?
Gastroschisis?
Gastroschisis. Are we sure about that one? Are we absolutely sure?
Yeah, because it doesn't have it.
Yes, guys, come on. This is gastroschisis, right? What can we see with the maternal alpha-fetoprotein? Increase or decrease in gastroschisis? What can we see in AFP? Guys, they are open, right? No mid-sac. So what happens to the alpha-fetoprotein?
Increase?
It's leaking, so you have high maternal AFP. Is this associated with other disorders? Yes or no? Not usually, right? Not usually, okay? What are the complications of this gastroschisis? Short gut syndrome. Short gut syndrome. If you have time, Google short gut syndrome. So this is gastroschisis, high maternal AFP, not usually associated with other disorders. Complication, short gut syndrome. Next one, look at the next image. Defect in the midline covered by sac. What is this?
Omphalocele.
Omphalocele, excellent. Associated with what? Associated with what?
Trisomy 13 and 18.
13 and 18. Signs and symptoms of 18. Your Edwards.
Low ears, rocker bottom feet.
Clenched fist. They love that one. How about 13? Teresa. Your patao.
Was this one the cat-like cry?
Nope, that's cri du chat. Defect in chromosome 5. Think about what happens to the head. Holoprosencephaly. Right? And a cutis or something, a place of cutis. Go over that one, okay? So another one is Beckwith-Wiedemann syndrome. What is Beckwith-Wiedemann syndrome? You have big baby with glossitis, big tongue. You have ear pits, okay? That's high yield. In the vignette, they're gonna say ear pits, right? So Beckwith-Wiedemann syndrome. So yes, you're right. It is omphalocele.
Ear pits?
Excuse me?
What kind of ear pits? Like pre-auricular pits?
Yes.
Because you're reviewing stuff that we haven't, some stuff we've done in term 2, but
All right.
that Beckwith side, we haven't done that yet. I think that might be term 5.
So it's like big baby with big tongue and ear pits. So last one, if there's a defect in the midline, no bowel present, what is this? Umbilical hernia, right? Associated with what? Congenital hypothyroidism, also big tongue. Do we need to treat this one, repair? Not needed unless persists past age 2 or 3. A vomiting baby, 4-week-old infant with non-bilous vomiting and palpable. Olive? What are we thinking? Non-bilous vomiting and a palpable. Olive?
Pyloric stenosis.
Stenosis.
What's the metabolic complication? What happens to chloride? Increase or decrease?
It decreases, so you get metabolic
What happens?
alkalosis.
Exactly. What happens to potassium? Increase or decrease? Hypochloremic, hypokalemic, metabolic alkalosis. What's the treatment? Surgery or yes or no?
Yes.
Yes.
Surgery?
So you could do, yes, immediate surgery referral for a myotomy. 2-week-old infant, bilous vomiting. Pregnancy was complicated by polyhydramnios. It could either be intestinal atresia or annular pancreas. Intestinal atresia, don't forget, associated with Down syndrome, especially duodenal atresia. Next, 1-week-old baby with bilous vomiting, draws up his legs, has abdominal distension. This is malrotation or valvulus. Why? Remember the lad's band? It can kink the duodenum. What's the pathophys? The SMA, it doesn't rotate 270 degrees counterclockwise. 3-day-old newborn still has not passed meconium. What's our 2 diagnosis? No meconium for this newborn.
Hirschsprung.
Hirschsprung disease, right? How do we diagnose that? Direct rectal exam and then explosion of poo. Why? There is no ganglia. Or another one is meconium ileus. When I say meconium ileus, you say cystic fibrosis. Okay? How do we diagnose? Gastrographin enema. 5-day-old, former 33-weeker, so a preemie, develops bloody diarrhea. This is a necrotizing enterocolitis. We see on X-ray, air in the wall, pneumocystis intestinalis. Treatment, NPO, TPN. Risk factors, like for example, early introduction of feeds and formula. Last, 2-month-old baby, colic abdominal pain, current jelly stool with a sausage-shaped mass in the right upper quadrant. Easy, current jelly stool. This is your intussusception. How do we diagnose? Barium enema is both diagnostic and treatment. Okay, now let's do some.
Could the first one also be an imperforate anus?
Which one?
The three-day-old has not passed meconium.
It could either be, I want you to focus on Hirschsprung disease and meconium ileus. Okay, next one, let's do some, so that's your, for peds. Now, inflammatory bowel disease. Did you do this or no?
Yes, we did.
Okay, now let's do some work, right? Let me just, Jesus Christ. It involves the terminal ileum. What are we thinking? It involves the terminal ileum.
Would it be more like Crohn's?
Excellent, Crohn's. So it can mimic also appendicitis, okay? It can mimic appendicitis, right? What else? Iron deficiency for Crohn's, okay? Next, continuous involving rectum. So it's a continuous, it involves the rectum. What are we thinking? Crohn's or UC?
UC.
UC. Excellent. Good job, guys. Right? Next, increased risk for PSC, primary sclerosing cholangitis. UC or Crohn's?
UC.
UC, right? PSC, there's C in there, UC. Why? PSC can lead to higher risk of cholangiocarcinoma. Next, fistula likely. You can have fistula. Crohn's or UC?
UC.
Careful, fistula formation. Fistula is Crohn's, exactly. What can we give? Metronidazole. Granulomas on biopsy. Crohn's or UC?
Crohn's.
Crohn's. Transmural inflammation. Crohn's or UC? Transmural inflammation, meaning all layers are inflamed. Crohn's. Okay, Crohn's. Next, cured by colectomy. Colectomy meaning we remove a part of the colon, which is curative by colectomy.
UC.
UC, of course. Smokers have lower risk. Controversial. They say it's protective, right? Although I don't like to use that word. It is protective for, what is this, UC or Crohn's? Smokers have lower risk.
UC.
UC. So smokers have higher risk for Crohn's. That's why they say smokers, like smoking is protective for UC. Although I don't like to use the word protective, because you don't tell your UC patients, oh, go out and smoke, right? No, of course not. Highest risk of colon cancer. UC or Crohn's?
UC.
UC. So this is another reason why you need to do a colectomy. Right? P. ANCA, associated with P. ANCA.
UC.
UC. How about Crohn's? ASCA. Sarcomyces cerevisiae, right? Don't forget that one. Okay, so these are like high yield points between your Crohn's and the UC. You need to know the differentiating factors between the two. These are like imaging. You can have pyoderma gangrenosum. You can have thrombophlebitis. migratory thrombophlebitis, you can have the string sign. Now, LFTs and lab buzzwords, okay? So if your AST is greater than ALT and you have a high GGT, what do you think is this? What do you think you have? So AST is much higher than ALT and you have GGT, high GGT.
Alcoholic cirrhosis.
Alcoholic hepatitis, exactly. How about the reverse, right? You have ALT is greater than your AST.
Viral hepatitis.
Viral hepatitis. So I always, ALT is like liver specific, like liver. There's something in the liver that is damaging it. So it's viral hepatitis, hep B, all of your hepatitises, okay? Next, AST and ALT in the 1000 after surgery or hemorrhage. I don't know if you covered this one, but this is shock liver. This is your ischemic hepatitis. What if you have an elevated direct bilirubin? Elevated direct bilirubin. Is it conjugated or unconjugated?
It's conjugated.
Conjugated.
So like a post-hepatic.
Excellent. Good job. So it's after, right? So it's already been conjugated. So example, obstructive, right? Think about Dubin-Johnson. Think about Rotor syndrome. Next, elevated indirect bilirubin. Your unconjugated bilirubin is elevated. What are we thinking?
So like a pre-hepatic blockage or hemolysis.
Good job. So hemolysis, that's good. Gilbert's, right? Krigler-Najjar. What if your ALK phos and GGT, they are both elevated? ALK phos is very specific. Don't forget, high yield. ALK phos, if it's elevated, think about GB, gallbladder, right? Something obstructing. Cholelithiasis, cholecystitis, choledocholithiasis, think ALK phos. For this one, if you have ALK phos and GGT elevated, think about bile duct obstruction, right? If the patient has IBD, think about primary sclerosing cholangitis, PSC. What if you have elevated ALK phos, but your GGT is normal and your calcium is also normal? So only ALK phos is increased. So Paget's disease of the bone, you can have increase in hat size, like treatment with biphosphonates. What if you have anti-mitochondrial antibodies? Anti-mitochondrial antibodies. So if UC has PSC, right, primary sclerosing cholangitis, what's the other one? The other one.
Primary biliary cholangitis.
Primary biliary cirrhosis, right? So you treat them with bile resins. I don't think you know this one. Let's see. ANA positive and anti-smooth muscle antibodies. This is your autoimmune hepatitis, low yield, treat with steroids, okay? Next, high iron, low ferritin, low iron binding capacity.
Would that be like the inflammatory anemia?
I'm thinking about, you have hepatitis. Okay, this is the clue. Hepatitis, golden skin, a bronze skin appearance.
Hemochromatosis?
Excellent. Good job. Hemochromatosis, right? High Fe, low ferritin, and low PIBC. Next, low ceruloplasmin and high urinary copper. Well, it's a given. Low ceruloplasmin, high urinary copper.
Wilson's.
Wilson. So you can have hepatitis, psychiatric symptoms, and don't forget the corneal deposit. Where is it deposited in the cornea? What membrane? Your Kaiser-Fleischer rings, right? In the cornea. Where is it specifically? Decimate membrane. Okay, don't forget that one. I had one question about that. One of the Q banks. Right, let's do here another review. A patient comes in with dysphagia, difficulty swallowing, guys, okay? So what is our best first test? Best first test. Doctors, I'm having trouble swallowing. I don't know what's going on. What is our best first test?
Would it be a barium swallow?
Excellent. You always do a barium swallow. Then what's the next best step? After barium swallow, what should be your next step? We still know it's not definitive, right? Barium swallow is not. So what's our next best, which can be diagnostic and allow biopsy for suspicious masses?
Endoscopy.
Excellent. Good job. Endoscopy. What is the test of choice for achalasia, or the best test for achalasia? The test of choice for achalasia, or the best test, or they say the most diagnostic test for achalasia. If you see this one, boom, it is achalasia. No ifs, no buts.
I think it's the barium swallow, and we'll see the bird beak appearance.
Think about the waves that they're gonna show you. This is definitive, right? Because for barium swallow, it can either be a stricture, right? You don't know. It could be like, yes, it could be
Would it be manometry?
Manometry.
Good job. Good job. So esophageal manometry. Guys, if you have questions, I'm gonna answer them at the end. Okay. Sorry, I can't yeah. So manometry is a test of choice for achalasia. Or someone can go to chat and because someone is asking a question, I'm not sure, and read it to me. Thank you so much.
It was answered already. What was the answer to the high iron, low ferritin, low iron binding capacity?
Okay.
Hemochromatosis?
Yep. So manometry, test of choice for achalasia. Definitive. This is your esophageal manometry. Next, how about the test of choice for GERD? The test of choice for GERD. What are we thinking? Test of choice for GERD, 24-hour pH monitoring. Test of choice for GERD, 24 pH monitoring. If you're HIV positive or otherwise immunocompromised, remember what kind of esophagitis can you have? Candida, what can we see in Candida esophagitis? White plaques, right? CMV, what kind of ulcer can we see in CMV? Linear ulcer. HSV, what kind of ulcer can we see? Punch out ulcer. All right, next. Okay, bad breath and snacks in the morning. What are we thinking? So the patient has halitosis, and then he keeps on eating. He keeps on regurgitating food. He keeps on eating in the morning, early in the morning. So there must be something wrong with the oropharyngeal muscle. Killian's triangle. So this is your Zenkers diverticulum, guys. So you treat this one with surgery. Is it a true diverticulum or a false diverticulum?
False diverticulum, because it doesn't contain all three layers.
Exactly. It only contains what? What layer? Mucosa. So next, if you have dysphagia to liquids and solids, so both liquids and solids, what do we call that? Look at the image here. Someone said it. Bird beak.
Achalasia.
Achalasia. What's the treatment? What can we give? You can give relaxants, muscle relaxants, right? So calcium channel blockers, right? Diltiazem. You can give nitrates. You can give Botox injection, or you can do a myotomy. Don't forget, associated with Chagas and esophageal cancer. Next, on the right, there's an image. Dysphagia, worse with hot and cold liquids, and you have chest pain that feels like MI with no regurgitation. Look at the image, corkscrew appearance. What do you think?
Chalasia?
Look at the image. Chest pain feels like MI or GERD. You check EKG, it's not MI, it's normal. You check troponins, it's normal. But then the patient said, oh my God, doc, I feel like it's like I'm having a heart attack. You check the imaging, it's the corkscrew. This is diffuse esophageal spasm, high yield, okay? Don't forget, it mimics MI. It mimics MI, but everything is normal, right? And then when you do imaging, you have diffuse, you can see the corkscrew. When you do a barium swallow, you can see this diffuse esophageal spasm. Treatment, calcium channel blockers, nitrates. Next, epigastric pain worse after eating or when laying down. You can also have coughing, wheezing, and hoarseness of the voice. What do you think? So we're just doing reviews now, okay? What are we thinking? Excellent, GERD, right? What's the most sensitive test? 24-hour pH monitoring, high yield. When can I do endoscopy? If we have dangerous symptoms that we talked about. So treatment with what? First, initial treatment, behavioral modification. Then you have your H2 blockers. And then you proceed to PPI. Okay? What are the indications for surgery for GERD? If they have bleeding, they have webs, they have strictures, they have Barrett's, right? Or if you've given maximum dose of PPI, still no resolution of symptoms. Next, if hematemesis, you can see pleural effusion with increase in amylase. What is this? So the patient is vomiting up blood, right? With subcutaneous emphysema. You look at the x-ray, oops, subcutaneous emphysema, right? Then you can see pleural effusion with an increase in amylase. What is happening to this patient?
Is a ruptured esophagus.
Excellent, excellent. So this is Boreham's. This is your esophageal rupture. What's the next test, best test? Do you give barium, yes or no? Do you give barium and kill the patient? No. So don't give barium here. Barium won't help you. Why? Remember, if barium and rupture, what will happen? Inflammatory response, right? So you give a much milder chemical. We call this gastrographin, your gastrographin esophagram. Do you need endoscopy for this patient? Yes or no? Do you need endoscopy for this patient?
I would say no, probably surgery.
Of course not. Why? Because there's a rupture, right? Where does your endoscope go? Through the rupture. You might punch something else, or you might widen the rupture, right? You might kill the patient. So no endoscopy. Someone said a treatment is always surgical repair, right? Next one.
What did you call the esophagram that we use?
Gastrographin.
Thank you.
No barium, because remember, if barium leaks, right, what will happen? Inflammatory response.
It'll go into the...
Yes, your peritoneum, you can have peritonitis. Do you want it in a patient that's already vomiting up blood with emphysema and pleural effusion? No. So if you have hematemesis unprovoked in a cirrhotic patient with hypertension, so coughing up blood still unprovoked in a patient that has cirrhotic with history of hypertension.
Esophageal varices.
Excellent. Good job. These are your esophageal varices. What is anastomosis for esophageal varices?
Is it the right gastric and the esophageal?
I
What
think
is
the
anastomosis for
left gastric vein and
left gastric and
it's the portal, and then the cable is going to be the esophageal tributaries of the esophagus and hemiesophagus.
okay. So your portacaval anastomosis. Right. Good job, guys. So what if the patient is in hypovolemic shock? So this is if the patient is in shock, right? Hypovolemic, what happens to cardiac output? Hypovolemic shock. What happens to cardiac output? Increase or decrease?
Decrease.
Guys, let's think. Hypovolemic shock. The patient is bleeding out or hemorrhaging, right? What happens? What's the compensatory mechanism of the body? What happens to cardiac output? Increase. What happens? Systemic vascular increase. Of course. In what type of shock is the SVR decrease? There are different kinds of shocks. You have distributive, you have obstructive, you have hypovolemic shock. In what type of shock is the SVR decreased? This is the only type of shock that your systemic vascular resistance is decreased, meaning your vessels are dilated. Septic shock. Remember your gram-negative bacteria, most common causes of your septic shock, your endotoxins, right? So if you have endotoxins in the blood, they will not gonna be constricted. They're gonna be dilated. That's the only type of shock where your SVR is decreased. So if your patient now is in hypovolemic shock, right? Don't forget ABCs, airway, breathing, circulation. You can do nasogastric lavage. You can give, what's the drug that we can give? For esophageal varices? Can we give beta blockers, guys? Yeah? Can we give a beta blocker?
I don't think we
Yes.
learned this.
No, this is term 2. Esophageal varices.
Did we learn treatments in term 2? I mean,
not
drug treatments?
But for this one, you can give beta blocker or octreotide. What is octreotide? Did you hear about octreotide?
Yeah, we learned about octreotide.
Okay, tell me now, what is octreotide? What kind of analog?
Oh, octreotide is a somatostatin analog, which is gonna vasoconstrict at the splanchnic.
What's the mechanism of action of your somatostatin analog? How does it decrease the bleeding? Someone said it.
I said it's gonna vasoconstrict the splanchnic.
Okay. Exactly. Right. Good job. So basically, right, it inhibits, the mechanism is it inhibits the release of glucagon, right? It inhibits the release of glucagon. And what is glucagon? It's a splanchnic vasodilator. So if you don't have glucagon, what happens to your splanchnic circulation? It will gonna constrict. That's the mechanism of action of your octreotide. Okay, can we do balloon tamponade? Yes, but if we're gonna transfer the patient, all right, we could what do you call that? The Blakemore, the balloon tamponade that we can use. What's the treatment of choice for gastric varices? How do we treat them?
Is it surgery?
Yes, we could inject like sclerosing agent, right? Endoscopic sclerotherapy, or we can banding, right? Don't prophylactically band your asymptomatic patients. You can give beta blockers instead. Next one, progressive dysphagia and weight loss. Weight loss, ding, 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 cancer. Progressive dysphagia and weight loss. So we're thinking about Esophageal carcinoma, two kinds, squamous cell and adenocarcinoma. Squamous cell, commonly seen in what? Smokers, drinkers. Where can we see it? Middle to upper, 1/3. Adenocarcinoma, commonly seen in what? Long-standing GERD. Most common site, distal, 1/3. What's the best first step? I yield initial test for esophageal carcinoma. Guys, the patient is having dysphagia. What did we say about
would it be
first
endoscopy?
Step? You can do endoscopy, but the first initial step. If a patient comes in, exactly, if a patient comes in dysphagia, that's the only reason, then you can do barium swallow, then you can do endoscopy, with or without biopsy. With or without biopsy? With biopsy, of course. Then we're gonna do staging, right? We're gonna stage it. All right, now guys, patient comes in mid-epigastric pain. So mid-epigastric, okay? Don't forget the landmarks of your abdomen, your OSCE, right? You have nine quadrants of the abdomen. Usually you divide it into 4, but I personally divide it into 9 quadrants, right? So you have mid-epigastric pain. So what is the number one cause? The number one non-ulcerative cause of a mid-epigastric pain. This is one of your diagnoses of exclusion. So meaning probably the pain is in the hypochondriac region. So don't forget dyspepsia. Dyspepsia is like you feel like the food you ate is not.
Is it cholestasis?
No, it's dyspepsia. The answer, yes, the answer is this pepsia. I don't know if you've learned about this.
Indigestion, right? So you just feel like full and bloated.
Exactly, fully bloated. Right?
Just
so
as
it's not the main diagnosis. Yes, it's only a diagnosis of exclusion. So we just treat it with the H2 blocker and antacid. So if GERD symptoms predominate, how do we treat them empirically? We treat them empirically with H2 blocker. What did we say about GERD? Which is the best for GERD? H2 blocker or PPI?
PPI.
Excellent. Always, right? Your ozol, omeprazole, pantoprazole. For 4 weeks, then you reevaluate. Patient comes in with mid-epigastric pain, and then biliary colic. What is biliary colic? Gallbladder. What happens to the sluggish, right? So you do a sonogram to check for the stones, right? If there's a history of stones or drinking, check amylase and lipase, and CT scan is the best imaging for pancreas. So if the vignette, they say pancreatitis, acute chronic pancreatitis, think about CT scan as the best imaging for the pancreas. When can you do endoscopic workup? You can do endoscopic workup when you have dangerous signs. 50 years old, history of smoking and drinking, recent unprovoked weight loss. It might be cancer, right? When you think weight loss, think about cancer. Or anemia, or melena, blood in your stool. Again, don't forget these ones, guys. Gastric ulcers, mid-epigastric pain, worse with eating. Think H. pylori, NSAIDs, steroids. You do double contrast barium swallow, which shows punch out lesion with regular margins. Okay, punch out lesions with regular margins. The EGD with biopsy can tell if it's H. pylori, right? Malignant or benign. How do we treat it? Sucralfate. What's the mechanism of action of sucralfate? Sucralfate. It coats the lining of your stomach, basically, right? Or H2 blocker or PPI. You do surgery if ulcer remains status post 12 weeks of treatment. You give all the medications, If it's still refractory to treatment, you do surgery. Duodenal ulcers, mid-epigastric pain, better with eating. Why is it better with eating? For duodenal ulcers. So when you're
Is
eating,
it because the food kind of soaks up some of the acid?
so gastric ulcers, pain worse with eating. Why? The food stimulates the production of acid, right? And where is the ulcer? In the stomach. So when you're eating, it provokes the ulcer. It's very, very painful. That's why pain is worse with eating in gastric ulcers. That's why they're cachectic. However, in duodenal ulcers, the pain is better with eating. Why do you think?
Production of bile.
Is the acid kind of neutralized by then, by the time it gets to the duodenum, but the coating from the food helps it?
Where is the ulcer? In the duodenal ulcer. Duodenum, right? What is in there?
Right.
The duodenum. Acidic or basic?
It's more alkaline.
It's more alkaline. Correct, right? When does it produces this alkaline juice, your CCK, all of those good stuff? When? When there is food, right? So when there is food in the duodenum, you secrete all of these alkaline substances so you don't irritate the ulcer in the duodenum. That's why when people who have duodenal ulcers, they keep on eating and the pain is better with eating. So you expect them to be somewhat bigger, like the weight is much higher, right? So don't forget, 95% associated with H. pylori. So the question mark here, the answer is H. pylori. Healthy patients less than 45, you can do a trial of H2 blocker or PPI. You can also do a lot of things. Stool, breath test for H. pylori, but endoscopy with biopsy is the best because it can exclude cancer. How do we treat H. pylori? High yield again, PPI, clarithromycin, amoxicillin, right? Your triple therapy. However, if they are resistant to clarithromycin, you need to do quadruple therapy. And then breath test can be test of cure, meaning after you've done your therapy for 2 weeks, right? You need to do another test, another breath test or stool test to confirm if your treatment works. This is what we call test of cure, okay? Just to confirm if the therapy works. Zollinger-Ellison syndrome, suspect if the pain or the ulcers doesn't improve with eradication of H. pylori, or you have a large multiple located ulcers. What's the best test for Zollinger-Ellison syndrome? High yield secretin stimulation test. Why is this much better than the other tests? Because it only stimulates those cells that has gastrinoma, right? Those abnormal cells that secretes high gastrin. It only stimulates those cells. So it's much more specific, right? So how do we treat this one? Resection if localized, long-term PPI if metastatic. High yield. If you're suspecting gastrinoma, Zollinger-Ellison syndrome, we need to look for an associated disease.
Peptic ulcer disease?
No. Did you know? Did they talk to you about MEN1, MEN2A, and MEN2B? No.
Yeah, it was a DLA.
Oh, so that's it then. Think about MEN1, specifically MEN1. What's the difference between MEN1 and MEN2? MEN1 has pituitary. What else? Parathyroid, and what else? What's the other one? Pancreatic, right? So MEN2A and MEN2B, what's the difference then? Why is MEN2 separated into A and B?
The second one
Uh,
of the lips and the tongue, and also has a marfanoid habitus.
Good job. So MEN2A, don't forget, medullary thyroid carcinoma, right? We're going to talk about that in the endocrinology section. Pheochromocytoma and hyperparathyroidism, right? That's your MEN2A. MEN2B, you have medullary thyroid carcinoma, and then you have pheochromocytoma. There's a good image on first aid, like MEN2A and MEN2B. In MEN2B also, don't forget, you can have mucosal neuromas. Someone said it, marfanoid body habitus, right? But you don't have the parathyroid hyperplasia in MEN2B, right? Okay, let's summarize that one because this is high yield. MEN1, pituitary adenoma, parathyroid hyperplasia, pancreatic tumors. MEN2A, parathyroid hyperplasia, medullary thyroid carcinoma, pheochromocytoma. MEN2B, mucosal neuroma, marfanoid body habitus, medullary thyroid carcinoma, pheochromocytoma. Those are high yield, guys. Please remember those. Next, acute cholecystitis. Now we need to be sure about the terms that we're using. What the hell is cholecystitis, choledocholithiasis, ascending cholangitis, right? So acute cholecystitis, you have right upper quadrant pain, you have nausea, vomiting, and fever. It is worse after fatty food. Positive Murphy's sign. For your OSCE. How do I know if the patient has a positive Murphy's sign?
You'll press in the right upper quadrant, and
what happens if I press?
They'll experience pain.
Careful. Specifically, what will happen?
I think rebound tenderness.
Cessation of what?
In the right quadrant.
So you
I
ask
press
for
the right
inspire.
quadrant. Excellent. You have cessation of inspiration. When you press it, you have that cessation of inspiration. Okay, that's specifically Murphy's sign. I remember I did this in one of my patients. My attending asked me, okay, Nick, show me a Murphy's sign. That's why I remember it, right? So you press it, and then they cease inspiring for a couple of seconds. They don't breathe in for a couple of seconds. They experience pain. That's your positive Murphy's sign. What's the best first test in acute cholecystitis? Best initial test in acute cholecystitis.
Ultrasound.
Excellent. Remember the keyword, initial test. Why do I need to do an ultrasound first?
It's the least invasive, least expensive.
What can I see in ultrasound?
Stones?
Gallstone.
So thickened wall. You can see thickened wall, and what else? Pericholecystic fluid, right? You can see like fluid on the gallbladder. All right. So the HIDA. So look at the image exactly. Someone said, Clint says, look at the image here. This is the image, the ultrasound image, right? You can see thickened wall. You can see the walls are thickened, and sometimes there's a fluid there around your gallbladder. The HIDA scan, it shows non-visualization of your gallbladder. So how are we going to treat cholecystitis then? Cholecystectomy. Cholecystectomy, you remove the gallbladder. If too unstable for surgery, what can we do? We could do a percutaneous cholecystostomy. You can do a tube, a draining tube there. So that's acute cholecystitis. Next one. So cholecystitis, you have stones there, right? Then what happens? It can dislodge. It can go through the common bile duct. Then we have choledocholithiasis. Same signs and symptoms plus obstructive jaundice. You have high bili and alkphos. Okay, So what can we see? Ultrasound will show stones, right? Now here you can do cholecystectomy or ERCP. When you go to the hospital, there's another test called MRCP. What's the difference? MRCP is diagnostic only. ERCP is both diagnostic and therapeutic. So the correct answer on the exam is always ERCP for choledocholithiasis. If there's no cholecystectomy there, then do ERCP. So the stone is there, in the common bile duct or in the ampulla of Vater, right? Is that a problem? Yes. Why? You can have bacterial infection, right? There's a blockage there, you're going to build up pressure, and then you can have infection. You have ascending cholangitis, pain, fever, jaundice. Oh, by the way, since we're talking about gallbladders, Charcot's triad, what is it? In ascending cholangitis, what's Charcot's triad? Charcot's triad. So you have pain, fever, and jaundice, plus Raynaud's pentad. Raynaud's pentad. You add what? Hypotension and change in mental status. Okay, that's very important, guys. So when you're doing rounds, the attending will gonna ask you what is Charcot's triad and Raynaud's pentad. Okay, for ascending cholangitis, you have that. This is the answer. Are you right upper quadrant pain, fever, and jaundice? That's your Charcot's triad plus hypotension and AMS, Raynaud's pentad. That's why 5 pentad, penta 5. How do we treat them? Fluids and broad spectrum antibiotics, ERCP also, and stone removal. Last.
What was AMS? Tachycardia?
No, altered mental status, guys.
Oh, altered mental status.
Yes, altered mental status. Cholangiocarcinoma, very rare, right? So risk factors is, we talked about inflammatory bowel disease. I want you to make that connection. Risk factor is what? For cholangiocarcinoma. Primary sclerosing cholangitis, ulcerative colitis. Another one is
Liver fluid.
Excellent. Your Clonorchis sinensis. Good job. So your liver fluke, right? How do we treat them? Surgery. So we treat them with surgery. Next, acute pancreatitis. So you have gallstones and alcoholism, most common etiology. So you have mid-epigastric pain. So you have back plus nausea and vomiting. OSCE, Turner sign and Cullen sign. What is Cullen sign? They're gonna ask you, what is Cullen sign?
Where you get the superficial bruising?
Where? Excellent. Where?
Around the umbilical area.
Good job. Paraumbilical region. Excellent. So you have a superficial bruising. You have an ecchymosis actually in the paraumbilical area. That's Cullen's sign. How about Turner's sign? Where is the ecchymosis? In the flanks, right? The flank region. That's your Turner's sign. Don't forget that, guys. When you're in the hospital, the attending will gonna ask you these signs. So labs show what? If the patient has acute pancreatitis, what will the lab show? Increase in what? Amylase. If it's more than 1,000, it means that there's a stone. And lipase. What's the best imaging technique for acute pancreatitis? Best imaging.
Ultrasound.
CT scan. CT scan is the best imaging technique. How do we treat them? Nasogastric tube, NPO, and IV, and then observe. What's the prognosis? Worse if old, all of that, you can read that. What are the complications? Pseudocyst, hemorrhage, abscess, acute respiratory distress syndrome. If it's chronic pancreatitis, you can have chronic mid-epigastric pain, malabsorption, steatorrhea. It can cause splenic vein thrombosis. For adenocarcinoma, they usually don't have symptoms until if it's advanced. If it's in the head of the pancreas, if the carcinoma is in the head of the pancreas, what do we call that sign, guys? Another one for your OSCE. What do we call that sign? If it's in the head of the pancreas. Did you hear about Courvoisier sign? You have itching, you have jaundice, and you have a large, non-tender gallbladder, right? Remember, if the cancer is in the head of the pancreas, what organ is closest to the head of the pancreas? Your gallbladder. So you have a large, non-tender gallbladder. We call this one Courvoisier sign. And you can also have Trousseau sign. What is this, guys? Trousseau sign.
That's the generalized thrombolytic, right? Trousseau sign.
This is migratory thrombophlebitis. Please know these signs, okay? How do we diagnose adenocarcinoma? Ultrasound and fine needle aspiration biopsy. We treat them with what? Whipple, pancreaticoduodenectomy. If there are no metastases outside the abdomen, there's no extension into the SMA or portal vein, no liver metastasis, or no peritoneal metastasis. Last stretch, diarrhea, before we go to endocrinology. So a patient comes in with diarrhea, hypotensive, tachycardic. What can you give first?
Just fluid replacement therapy.
Excellent, excellent. So is it lactated ringers or what? Or normal saline? What's the difference?
Between normal saline and what, I'm sorry?
And lactated ringers?
I have no idea, but I'm gonna go with normal saline.
So because they are hypotensive tachycardic, right? You need to give sodium, NS, you have sodium and chloride, right? Lactated ringers, the only thing that NS doesn't have is phosphorus. It's not complete, your normal saline. For lactated ringers, it's complete, it has phosphorus. So viral is the #1 cause of diarrhea. Okay, tell me the virus in daycare kids. What virus?
Rotavirus.
Excellent. Cruise ships?
Norovirus.
Norovirus, Norwalk, yep. So you check the what? The fecal leukocyte, and it tells the invasion, right? So stool is the best test. If you have a bloody diarrhea, think about EHEC, Shigella, Vibrio parahemolyticus salmonella, EH. If there's a history of picnic, think about staph food poisoning, Ceres, B. Ceres. If there's a history of antibiotic use, check for C. diff antigen. Right? If the patient in the hospital has been there for too long, history of antibiotic use, check stool for C. diff antigen. If there is a foul-smelling, bulky, malnourished-looking patient, think about Whipple's disease, think about CF in a young person, think sprue, think about chronic pancreatitis. If you have flushing, tachycardia, hypotension, think about carcinoid syndrome. Don't forget, it can also cause what? Vitamin deficiency.
B12.
B12, are we sure about that? Carcinoid syndrome. What's increase in carcinoid syndrome? Increase in 5-HT, serotonin, correct? So if you have, where does serotonin come from? Where does it come from in the body? Think. What is the precursor, guys? Term 2, what is the precursor of 5-HT?
Tryptophan.
Excellent, tryptophan. And what deficiency? If you're using all your tryptophan 5-HT, it can cause what vitamin deficiency? Dementia, dermatitis, diarrhea. What is that?
C deficiency.
Niacin deficiency. Good job. See, we're integrated, right? Carcinoid syndrome, it can cause niacin deficiency. Why? Secondary to what? You use all your tryptophan to make 5-HT. So don't forget dementia, dermatitis, diarrhea. All right. Before we go to endocrinology, can we have a couple of minutes break? Please, it's 12 o'clock.
Yeah, go eat something.
Okay?
Go get some.
How many minutes do you think?
Well, you probably need to have lunch, right? Because you get up early. So maybe at least 20, 30 minutes.
12:30? Is that good?
Yeah, 12:30 sounds good.
Okay. All right. See you later, guys. Thank you.
Are we going to have another call or should we just mute?
The same link. The same link.
Okay. Thank you,
All
Nick.
Thank you, Nick.
Enjoy your lunch.
Yep, you too, guys.